Hello and welcome to Health Talk. I'm your host, Angela Baracco-Eddy. With me tonight is Dr. Wayne Adkisson. He is a board-certified gastroenterologist with the Sacred Heart Division of Gastroenterology Associates. You can find him at Sacred Heart Hospital and their offices in Pensacola, Pace, and Bruton, I believe, and all those places.
That's right.
As well as the Endoscopy Center on Davis Highway. And of course, the Endoscopy Center is kind of the overall host of the show. And you can find a lot of information about the Endoscopy Center and the various offices where the physicians see patients on the Endoscopy Center website. And that will be on the program throughout the evening. But it's www.endo-world, there it is, endo-world.com. That website has a ton of information, not only contact information, how to get in touch with the various offices, but information about the different physicians, some frequently asked questions, links to other websites. There's really a lot of very good information on that website, so check that out if you have any questions. And tonight's topic will be pancreatitis. So we will be talking in great detail about the pancreas, about conditions, concerns, diseases of the pancreas this evening. We are live, so if you have a question or a comment, feel free to give us a call. We'd love to get you on the air. The numbers will be on the screen throughout the program, 432-7768. Or if you're outside of the Pensacola area, the toll-free number is 1-800-950-2522. And again, feel free to give us a call if you have a question about the pancreas or pancreatitis or anything having to do with gastroenterology. We'd love to talk to you this evening. So all of that kind of housekeeping stuff out of the way, Dr. Adkisson,
Nice
good
to
to
see you. Thank you.
So tonight we're going to be talking about pancreatitis, and let's kind of back up and start at the very beginning. What is the pancreas?
Well, the pancreas is an organ, an intestinal organ that sits in the abdomen. It's beneath or behind the stomach, deep in the abdominal cavity, up against the spine. And it's an organ that does two major functions. One we call the exocrine function, and that's where the gastroenterologists come into play. The pancreas synthesizes two enzymes, lipase and amylase, that help you break down food components or dietary components in your foods that you ingest. And there's another component that's the endocrine function. There are special cells within the body of the pancreas that secrete various peptides or hormones that do various things. These are secreted into the bloodstream and have functions throughout the body. That's called the endocrine function. So for the GI side of the talk, we're going to be interested really in the exocrine function of the gland. But it is located in the abdominal cavity, recessed up against the spine, behind the stomach.
And if the pancreas is working well, everything is going fine, you don't have any symptoms, everything is good. But if the pancreas gets out of whack or something starts going wrong with it, what are some of the symptoms that someone might have if there's a problem?
You can have several diseases of the pancreas. What we're going to talk about tonight is predominantly inflammation of the pancreas called pancreatitis. And that comes kind of in two flavors. There's acute pancreatitis, which is going to be the bulk of the talk, and then there's chronic pancreatitis, which is a little bit different, and we'll talk about that. But other pancreatic problems you can have cancer of the pancreas, and people are quite aware of that. You really don't have infections of the pancreas. That's a very uncommon type thing. You may have strictures or stenosis in the plumbing, and you have various types of cancers of the pancreas. But symptoms that someone might have, a lot of times cancers of the pancreas are asymptomatic. You don't have any symptoms at all until it's quite advanced. Then you may begin to have some symptoms. Acute pancreatitis, you have symptoms very early, and those are symptoms of upper abdominal pain, usually that can radiate to the back, because remember the pancreas is up against the spine. Abdominal pain radiating to the back, usually with some nausea, vomiting.
What are some of the causes, and I know we're going to talk about this throughout the whole program, but what are basically some of the basic causes of acute pancreatitis?
So acute pancreatitis means that there's active inflammation in the gland itself. And the number one cause, believe it or not, in the United States is gallstones. Because the anatomy is such that the gallbladder and the bile duct, which is the drain duct from the liver and the gallbladder, has to pass through the head of the pancreas and exit to the small bowel. Well, it has to pass through the pancreas, and it also merges with the main drain tube from the pancreas. So it's like two pipes. You know, they come from different directions, and they empty through one little opening into the small bowel. And believe it or not, problems with the bile duct pipe, if it gets blocked, it can cause problems in the other pipe, the pancreas. Okay, so problems with your biliary system is actually the #1 cause of acute pancreatitis in the United States. #2 would be alcohol, excessive alcohol exposure. Drinking 4 or 5 drinks a day, it takes a pretty heavy amount of alcohol for a period of time, can actively inflame the pancreas. We don't really know exactly how this happens or why it happens, and it doesn't happen to everyone that drinks heavily, but it's very common. So gallstones, alcohol, then there are miscellaneous other causes. It can be a side effect associated with some medications. There's a long list of possible culprits in that arena. If your calcium level gets too high, that can cause it. If your triglyceride levels in the blood get too high, that can cause it. So, and then there are genetic problems that we're just now beginning to learn more about. People that have certain genetic issues with membrane transport agents and various things are genetically susceptible to more inflammatory responses in the pancreas. And that accounts for a small percentage of cases, but it's known, and we're learning more about that.
Are there specific risk factors that someone might have that might put them more prone to have pancreatitis or some sort of diseases of the pancreas, or is there a family history component that goes along with that?
Well, if you look at the causes, say if the #1 cause of acute pancreatitis is biliary disease, blockage of the duct, you look, what would cause those things? Well, stones in the bile duct. What causes stones in the bile duct? Obesity. People that have, and we've talked about this many times on the show, there's an obesity epidemic in the United States, which is now spreading to other countries around the world. So things linked to that, causing biliary issues of stones and sludge, can predispose you to pancreatitis. Diabetic patients often have obesity as a coexisting problem. Those patients are at higher risk, those sort of things. And alcohol, of course. Alcohol exposure increases your risk of pancreatitis.
Is age a factor?
Well, not necessarily, because any one of those things can affect people at any age. Rare in children, though. Much more common in adults.
Okay, adults, but young adults, older, it doesn't
That's right.
make too much difference. And male, female, does that have?
Pretty much equal. Maybe more female because of the bile duct issues, so maybe more women with stones and gallbladder issues than male.
Are there certain dietary changes or lifestyle changes that someone could make to either avoid getting pancreatitis, or if they do have acute pancreatitis, to keep that from ever coming back?
Well, I guess in order to try to avoid any kind of pancreatic problems, you want to avoid obesity. So you should eat a lean diet, a healthy, lean diet, and try to avoid obesity would be one of the best ways to try to avoid any pancreatic problems. During the setting of acute pancreatitis, we usually give bowel rest, meaning we will not let the patient eat solid foods for a few days, allowing the pancreas to kind of rest. Because once you ingest food, that's a stimulus for the pancreas to begin to secrete those enzymes. So we don't want to stress the pancreas during that time. So we'll hold the patient without solid food. We'll let them have liquid diet, clear liquids, broth, jello, pudding, that sort of thing. And that's okay. And sometimes we advocate a low-fat diet for people with pancreatic disease.
And of course, avoiding alcohol, I'm sure. If that's one of the causes, then that's one of the things that you
And smoking,
try to
actually.
avoid.
Smoking coexists. It goes with that. Smoking exacerbates, or patients that are smokers have a higher risk of pancreatic problems as well.
What are some of the basic treatment options that are available for acute pancreatitis? We're going to get into the chronic in a few minutes, but let's talk about acute. What are some of the things you can do? Putting them on the liquid diet, but are there medications, or if it stays bad, is there surgery?
Well, acute pancreatitis is a range of presentation. It can be very mild, where the patient just has some abdominal pain, maybe some nausea, vomiting. They have some blood work done, and they have what we'll call some biochemical abnormalities. And that can be very mild, responds just to bowel rest and maybe some IV fluid hydration within a couple of days. That's mild. And that's the vast majority of cases. 80% or more of hospitalizations for acute pancreatitis are mild pancreatitis. Then some patients have a much more severe course of pancreatitis, and that inflammation is so intense that it actually destroys part of the organ. Okay, that's called pancreatic necrosis. The part of the pancreas itself begins to die. That's very severe. That could ultimately result in death of the patient. So acute pancreatitis is a broad spectrum of severity, from mild, just resolving with IV fluids and bowel rest, to multisystem organ failure and death. So it's a broad spectrum.
And when someone is having some of these symptoms, you mentioned the blood work. Is the blood work the diagnostic tool? Is that how you diagnose that it's pancreatitis?
The diagnosis of acute pancreatitis is based upon the clinical history, the story, the presentation of the symptoms, pain in the right location, typically with nausea, vomiting, in conjunction with blood work abnormalities. And we're talking about lipase and amylase. Those are the enzymes that the pancreas makes. They have to be elevated in your bloodstream 3 times higher than the typical normal range. Everyone has some level of these enzymes circulating all the time. But when those 2 enzymes are over 3 times the normal limits, that's considered diagnostic. So the classic symptoms, the biochemical abnormalities, and there may be imaging, such as a CT scan of the abdomen, can show inflammatory change in and around the pancreas. So that's how the diagnosis is made this day and age.
And let's kind of move into the chronic pancreatitis and what the difference is between acute and chronic.
Okay.
And then some of maybe the causes of the chronic.
So to get to chronic, you kind of have to go through some phases of acute. So with acute pancreatitis, your gland is acutely inflamed, you have pain, you're nauseated, you vomit, and it typically resolves. And it can resolve with very conservative care, or it may take aggressive ICU support. But typically, acute pancreatitis will resolve. Now, if a patient goes on to have multiple recurrent bouts of acute pancreatitis, every time you have a bout of acute pancreatitis, you do a little bit of damage to that organ, okay? And over a period of time, the damage can really begin to accumulate. And this really seems to be more severe in alcoholic patients and people that have alcoholic-induced acute pancreatitis. Over a period of time, they can have such scarring of the gland that it becomes almost non-functional. And when people begin to have scarring of their pancreas, this is what we term chronic pancreatitis, okay? So it's much different than acute pancreatitis. Chronic pancreatitis is the sequela of long-term incremental damage to the pancreas. Your pancreas is scarred. It can't make the enzymes that it used to be able to make for dietary purposes. You may have pain with meal ingestion. You may have chronic pain because it's so scarred up and there's damage done and there's nerve endings in the pancreas and they're affected by the scarring. So you can have chronic pain, pain with meals. If you can't absorb some of your nutrients, you may be left with diarrhea. These people may have diarrhea, malabsorption, and weight loss. So there's a plethora of problems that are long-standing that can occur with chronic pancreatitis.
But chronic pancreatitis is probably not something that you just all of a sudden have. It's something that develops through the stages.
That's right. Chronic pancreatitis is a long-term end result of incremental damage to the pancreas over a period of time.
Are there other diseases or conditions that can lead to the pancreatitis? You mentioned diabetes that might have something to do with that, but the obesity might be the factor in that.
Right, and usually it's the biliary issue. If you look at the causes of acute pancreatitis, again, it's going to be biliary, and there are certain patients that are more prone to that, obese patients, diabetic patients, that sort of thing. Then it's going to be alcohol, and it's going to be medications, and it's going to be hypertriglyceridemia, the high lipids, and again, that goes along with obese patients and diabetic patients. So those sort of things can predispose someone to acute pancreatitis.
What are the most common complaints of someone that's having acute pancreatitis when they're first coming in to see you?
Acute pancreatitis is going to be pain, pretty significant upper abdominal pain, nausea, vomiting.
And
those are the complaints.
Typically hospitalized when you've done that?
Once the diagnosis is made, again, based on the symptoms, the location of the pain, the blood work abnormality, you're hospitalized typically. Because the treatment is going to be fluid resuscitation with IV fluids. That's a very key component, a lot of IV fluids, and bowel rest.
And if it resolves on its own, hopefully within a few days, and then what what are the instructions that someone might have going home? Do they have specific dietary changes?
So what we're going to do if someone presents with pancreatitis is we're going to try to track down the cause. Okay, you're going to treat the pancreatitis with IV fluids and bowel rest and pain medication. That's going to be transient. It's going to be over within a few days typically. 80% of cases in the United States resolve and are mild. And so what we're going to be doing while we're treating the patient is trying to search for the underlying cause. What caused this problem? And then we're going to direct treatment to that underlying cause. So when someone leaves the hospital after a bout of acute pancreatitis, well, they can have varying instructions depending upon what we found. You know, if it's a biliary issue, then they have to go down a certain path to have the bile duct taken care of or the gallbladder removed. If it's an alcohol issue, they need to avoid alcohol when they leave the hospital. You know, if it's a triglyceride issue, their triglycerides too high, they need to be on medicines to get those down. So it depends upon what the underlying cause is. We may advise them they may want to be on a low-fat diet once they leave the hospital for a little while, but typically they can then resume their typical diet.
And of course, weight loss is probably part of that for a lot of people.
Sure. If someone is obese, then weight loss and a weight loss diet with exercise is going to be part of that recommendation.
It is time for us to take our first break. If you have a question or a comment, give us a call. We'll be right back, and we'd love to get you on the air when we come back with more Health Talk.
Your word is gastroenterologist.
Can I have the definition?
A physician who specializes in diseases of the digestive tract.
Can you please use that in a sentence?
When stomach pain persists, you should see a gastroenterologist.
Could you tell me where I could find one?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
G-A-S.
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me tonight is Dr. Wayne Adkisson. He is a board-certified gastroenterologist with the Sacred Heart Division of Gastroenterology Associates. And you can find him at Sacred Heart Hospital in Pensacola, as well as their offices in Pace and Bruton, and at the Endoscopy Center on Davis Highway. He has been in the Pensacola area about 16 years. We talked about that a little bit before the program, and the time sure goes by fast. One of those amazing things. But about 16 years he's been here in Pensacola working at different locations, the Endoscopy Center, Sacred Heart Hospital. And tonight's topic is pancreatitis. We've been talking about the pancreas, its function within the body, different diseases and conditions that could possibly cause pancreatitis. If you have a question or a comment about the pancreas or about pancreatitis specifically, give us a call. We would love to get you on the air. The numbers are on the screen throughout the program. 432-7768, or outside the Pensacola area, the toll-free number is 1-800-950-2522. And again, we're talking about pancreatitis. One of the things that I asked Dr. Adkisson during the break is, does the pancreas sort of heal itself? If there's been damage, does it regrow, or does it get better after that damage? Or once it's damaged, does that damage stay forever?
Well, if it's just mild acute pancreatitis, the tissue of the pancreas is inflamed, and that itself can cause damage. We'll talk a little bit about the pathophysiology of pancreatitis. But if it's a mild acute event, then the inflammation subsides, and the process takes care of itself and simmers down, and you go back to normal. Now, if there is necrosis, if you're one of the few patients that have a very severe bout of acute pancreatitis and the inflammation is so severe that part of the actual gland and tissue begins to die, that's necrosis. Well, the body begins to absorb that tissue. It will wall it off. It's a very fascinating process. The body will zero in on this area. Your immune system will wall it off, and it will liquefy that area, and it will be reabsorbed, and then you'll have some scarring there. But the pancreas does not regrow. You know, you may hear people say the liver can regenerate or other tissues can regenerate. As far as we know, that does not happen with the pancreas. The pancreas can sustain some death, and the body will resorb and take care of that issue. But the pancreas, you don't grow new pancreatic tissue. But let's back up and talk a little bit about the process of pancreatitis and how the pancreas gets inflamed. The way I describe this to patients, the pancreas is a pretty small organ, and it's not very big. It's very deeply buried into the abdominal cavity, as we spoke about earlier. It's very protected. It is like a nuclear reactor. And the enzymes, or the liquid that's made by the pancreas, those enzymes are made to tear down tissues, to tear down things you eat in your diet, like meats and fats and those sort of things. Well, that's what your body is made out of. So those enzymes have to stay, it's like the nuclear fuel rods. They have to stay in the nuclear chamber. And as long as the nuclear fuel stays in the chamber, everything's fine. But if there's ever a crack in the chamber, then you got a big problem. And that's what happens with acute pancreatitis. The ductal plumbing system, once you have some inflammation started, and we don't know really what triggers the inflammation, but something happens to take these enzymes and activate them while they're in the system, and they can cause a perforation or a crack in the plumbing system, okay, a crack in the casing. And then these digestive enzymes leak out and begin to actually destroy the tissue that it comes in contact with, which would be your own body, your own pancreas, the tissues around the pancreas. And this is when you begin to have very complex cases of necrosing pancreatitis and what we call fluid collections. These burrowing enzymes will go through, tunnel all through what we call potential spaces, the places where, say, two organs are adherent to each other. When there's a potential space between, well, these enzymes will burrow down through, and it can dissect through all kind of intricate places throughout the abdominal cavity. And so that can get quite complex and complicated because of, think of it this way, your nuclear reactor melted down and the enzymes got spilt out of the chamber, and that can be very bad. Those sort of patients can have a very long, very complex, complicated medical course, okay? And death is a consequence of severe necrotic pancreatitis. It's low this day and age with advances in medical care, but still people do die from acute pancreatitis because of those reasons.
Is that something, if there's that leaking that's into the body, is that something that happens quickly, or is that something that kind of goes slowly over time?
This happens, well, quickly meaning over a course of a few days.
A few days is quick.
Yeah. So someone comes in with acute pancreatitis, and you know, we have a few little ways you never know. When somebody presents, you don't know how sick are they going to get, okay? That's one of the reasons that people with acute pancreatitis, regardless of how severe it appears, typically get admitted to the hospital for observation, if for nothing else, some IV fluids and at least observation, because you never know how severe it could be, or it's going to be. And this process plays out over a few days. And so we're monitoring these patients constantly throughout the hospital course, watching to see how this goes. Because if they develop one of these breaks in the system, in the plumbing, and the enzymes get out, then they could be in for a very long, complex hospital course.
Is there a surgical option in something like that? I mean, the pancreas is small and it's tucked away and it's kind of hard to get to.
Right. So the only time you would do any type of surgical or drainage procedure is, say, someone has an acute necrotizing pancreatitis and a very significant portion of that gland has died because of this. And these enzymes have gotten out and leaked around the abdominal cavity and caused fluid collections or what we call necrotic collections. And If these things become infected, sometimes bacteria can get into those collections of dead tissue. That can be life-threatening. And so at that point in time, you may need a surgical intervention to actually go in and clear out this material. That's called a pancreatic debridement. So pancreatic debridements are done in the United States, but now there are some alternative methods to try to get that material out of there. The interventional radiologist can put catheters into the collection and drain it and flush and drain and flush and drain. There are some institutions in the United States where they will actually go through the skin, make a surgical incision, and then put an endoscope through the skin into one of these collections, debride it with a scope that way. So as technology advances, there are more ways other than to just surgically go in, and what they have done is a necrosectomy where they scoop out this material physically. But that may be needed in severe cases, but that's rare.
How common is pancreatitis? Is that something that you see every day, every week, every month?
It's very common. We do see it commonly. There's a recent New England Journal article that estimates there are about 280,000 admissions to hospitals for acute pancreatitis in the United States. It estimated that those 280,000 admissions cost a couple of $1 billion in healthcare spending. And looking at statistics over the past several decades, it appears that acute pancreatitis is on the rise, that we're seeing more now than we have in the past. Again, that's been attributed to obesity syndrome and maybe diabetes associated with that, but that's unclear.
And it sounds like there's not really any definitive diet that can help you avoid. It's more just general lifestyle, eat healthy, stay in good shape, things like that.
That's right.
So unfortunately, there's not a magic, if you eat this, then you won't have...
Right. There's no wonder diet. No.
It would be nice.
And another area that we're learning, we have our top 3 or 4 causes that are pretty common. Biliary issues, alcohol exposure, some of the medications, a long laundry list of medicines that can do it, the high triglycerides, the high calcium. Then remember we said there's a subset of people that we're learning may have some genetic disorders. And what we're learning is that there are various membrane transporters, there are various biochemical things going on in the pancreas, and people can be born with genetic abnormalities in some of these things that affect the function of the gland. In the past, there were about 25% of cases of pancreatitis we never could figure out the cause. It wasn't biliary, it wasn't alcohol, it wasn't any medication, it wasn't all these other things. We ruled out all these things that cause pancreatitis and none of it popped up. And we call those people idiopathic, meaning we don't know. It's idiopathic pancreatitis. We never could figure out what it was. And that still happens today. We still have patients, we run the list of all the possibilities and none of those boxes are checked. It doesn't add up. And it may be that some of those people actually have underlying biochemical or genetic issues that are yet to be quite determined or elucidated, that somehow predisposes them to have this activation of the enzymes in acute pancreatitis.
Which is something interesting, in that genetic component of medicine is just growing in leaps and bounds. It seems like every month when there's a doctor on, we're talking about something having to do with genetics and whatever the condition is.
Right.
So lots of growth in that area. Does acute pancreatitis, which then might develop into chronic pancreatitis, ever lead, or could it lead to pancreatic cancer?
Well, not that we know of. Acute pancreatitis, no. Acute pancreatitis is acute inflammation of the gland. It resolves. Now, if someone has chronic pancreatitis and severe chronic pancreatitis, it doesn't directly lead to cancer. It's not an outstanding, known, big risk factor for cancer. That being said, however, what we just spoke about is people that may have these underlying genetic issues that predisposes them to chronic pancreatitis or to any kind of pancreatitis. They may have some smoldering inflammation in their gland through the course of a lifetime that they don't necessarily know about, and that smoldering inflammation may predispose them to cancer, may predispose them to chronic damage, okay? And so it's unclear. It's not a huge known risk factor, but people with chronic pancreatitis can are sometimes associated with the pancreatic cancers, but it's not very clear.
So it's not that it's a precursor to. It's not that
it doesn't appear to be.
But it doesn't.
It's not well elucidated. Let me tell you that. Because also the people that have chronic pancreatitis typically are the people that drink and smoke. Both those things are aggravating factors, and it's hard to know what was the risk factor there.
Right. Right. So again, the healthy lifestyle is what's going to be more important.
And you flip that around, most of the people that have pancreatic cancer never had any bout of pancreatitis ever in their life. Totally different thing. So are those two related? Well, maybe, but if so, only a small percentage. We haven't worked out that exact relationship.
And one of the things that you said earlier is oftentimes with pancreatic cancer, there are no symptoms. And yet with pancreatitis, there are definitely symptoms. So that's another big difference between.
Correct. Pancreatitis, acute pancreatitis, you are symptomatic up front. I mean, from the very beginning, from the time it starts, you begin to have symptoms, and you're symptomatic through the course. Pancreatic cancer can grow silently for years and years until it is such a late stage that then you present with complications of the disease.
Let's talk just briefly about pancreatic cancer. That's something that we often will get calls on because a lot of people have experienced that within their family. They know someone or they're related to someone who has had pancreatic cancer. Let's talk about the stages of pancreatic cancer, why it is something that's typically found so late.
Okay. Well, because predominantly the cancers grow very slowly and silently. Now, remember, the pancreas is a small organ tucked way back in the abdominal cavity against the spine. And these cancers, if they grow in an area of the pancreas, say the body or out into the tail of the pancreas, they're not going to interfere with anything else going around or nearby for the most part. So when very early on, they're not going to run up into anything or cause any damage, so to speak, that would make you symptomatic. If the cancer, remember we said there's bile duct pipe, there's a bile duct pipe going there. If the cancer happens or grows in the neighbor of that bile duct pipe in that area, and it begins to choke the bile duct pipe, well then that would present, patients would present symptomatically from that process. Okay, but part of the problem is it grows so slowly over a period of time, and it doesn't necessarily cause pain. Okay, and you still have plenty of other healthy, functioning pancreatic tissue doing the daily work to get you by, so you don't have symptoms.
It's a scary thing, and that's typically a bad one because, as you said, there's no symptoms early on, and so when you do discover it, it's usually late in the game. It is time for us to take another quick break. If you have a question or a comment, give us a call. We'd love to get you on the air when we come back with more Health Talk.
Your word is gastroenterologist.
Can I have the definition?
A physician who specializes in diseases of the digestive tract.
Can you please use that in a sentence?
When stomach pain persists, you should see a gastroenterologist.
Could you tell me where I could find one?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
G-A-S.
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me tonight is Dr. Wayne Adkisson. He is a board-certified gastroenterologist with the Sacred Heart Division of Gastroenterology Associates. Tonight's topic is pancreatitis. We've been talking in quite a bit of detail about the pancreas, the function of the pancreas, what happens when something goes wrong with the pancreas, and what are some of the different things that the treatments, the different courses that you go through if you are diagnosed with pancreatitis. We are live this evening, so if you have a question or a comment about the pancreas or specifically pancreatitis, we would love to get you on the air. The numbers will be on the screen throughout the program. I think they're flashing them right now. 432-7768, or if you're outside of the Pensacola area, the toll-free number is 1-800-950-2522. And we were talking earlier in the program about some of the causes of acute pancreatitis, and sometimes that can be gallstones. And that's kind of part of the biliary system. And so I want to back up and talk a little bit about the gallbladder and gallstones and some of the causes of gallstones, and then treatment options to possibly prevent that from getting worse.
Sure. So the biliary system is the drainage system of the liver, and the liver makes the substance that we call bile. And this bile is a liquid that is a yellowish golden kind of colored liquid that is made 24 hours a day by your liver, and it's excreted down this main drain tube called the common bile duct out into the small bowel. And this liquid helps you digest predominantly fatty ingredients in your meal. Okay, it helps you break down fats. And if you've seen soap, okay, think of it this way: soap and fat in your plates after dinner, and you see fat bubbles and you put the soap in, it helps emulsify. It helps a process called micellization. It helps you break down the fat that you ingest in your meal. That's the role of this bile, one of the roles. And so the main bile duct drains this liquid into the duodenum, and there is a little storage area, a little storage sac. That's the gallbladder, and the gallbladder is nothing more than a storage sac to hold on to some of this liquid, this bile. And so when you ingest a fatty meal, that sends some biochemical signals to your gallbladder to contract, to squeeze, and to eject some of that bile into the duodenal lumen to help you emulsify those fats. Okay, so that's how the process works normally. Now the bile is kind of a tricky liquid. I try to explain it to patients. It's like oil and vinegar dressing. Okay, if you just lay the container, if you don't bother it, it wants to separate out. Okay, it's an emulsion. If you shake it, it all goes into, it suspends. It mixes up well. But if you let it lie static, it's going to naturally separate out. That's the way bile is. And so in your gallbladder, the bile just sits there, and it can separate out, and you can form sludge, sludgy debris. Okay, over a period of time, the sludge can actually form into a microcrystal. That can be the start of a stone that forms. And then before long, you have stones in your gallbladder. Okay, and this can create a whole other list of problems once you start developing stones in the gallbladder or stones in the bile duct tube.
And we've had some calls that have come in. I'm not sure if they're going to be related to the gallbladder questions or if they're going to be related to that, but we're going to get you on the air. We appreciate you calling in. Hello, and thanks for your call. Do you have a question or a comment for Dr. Adkisson?
Yes, I just tuned in. I had a question that didn't know if it was a little off topic, but I had a friend that had diabetes for years and years, and they were recommending a transplant of the pancreas. Is that a common thing, and is it something that she eventually died, but I just didn't know if waiting for the transplant, but is that something that can be done for people that have long-term problems with their pancreas? I'll hang up and listen. Thank you.
Thank you for your call. Thank you. That's a great one. I haven't heard that
so
one before.
pancreatic transplantation, now that by and large, pancreatic transplantation has not really met a lot of success. So what they've tried to do is what's called islet cell transplantation. You know, remember at the beginning of the show we said there are two functions of the pancreas. One is exocrine, that's secreting those enzymes, and that's the topic here that we're talking about, acute pancreatitis. But also there's a whole other side of the pancreas that you could argue is even more important. That's the endocrine function. And that's where insulin is made in your body. And if you don't have insulin, you're going to have diabetes. So, and there are various other peptides and hormones made by these special islet cells in the pancreas. So what they've tried to do is harvest some of these islet cells out of the patient and then grow them in a lab and then infuse them or inject them back into the patients. And typically what they do is they take up residence in the liver. And these islet cells then grow in the liver. This is not where God put them. They're taking up residence in a new location, but they're still functioning the same. And they will continue to secrete insulin and these proteins to help the patient survive. That's called an islet cell transplantation. Now that is becoming, believe it or not, more acceptable, and they're seeing more success with those. And of course, this is a highly sophisticated type of transplantation process. It's being done in a few centers around the United States and a few in Europe. But islet cell transplantation is something that we'll probably see more of in the future as the techniques are refined.
And are those cells specific to the insulin production, or are they also doing the enzyme production?
Not the enzyme production. It's the
peptide
and insulin type production. The enzyme production to help you digest, we can supplement those enzymes actually in the form of a capsule that you will take with your meals. Okay, so you don't need your pancreas to make those enzymes. Those can be formulated, put in a capsule, and you take them with your meals.
So really the function of the pancreas that you can't live without is the insulin and the other
hormone. That's right, the endocrine
peptide
function. That's the part you can't live without. The exocrine function, the digestion of enzymes, we can supply those in a capsule form.
Very interesting. We have another call that's holding. Oh, we just lost him. So thank you for your call. We're sorry that we didn't get to you in time. Hopefully we answered your question, and that's why you weren't able to hang on. If you do have a call, or if you have a question or a comment, give us a call. We would love to hear from you, and we will get that on the air. The numbers, again, are on the screen throughout the program. So we were talking a little bit before the calls about the biliary system. We were talking about the gallbladder and some of the reasons of gallstones, some of the different things like that. The complications of that biliary system that can lead to eventually, or potentially, I guess, pancreatitis. What are some of the other complications associated with the biliary system? Let's kind of go that direction for a few minutes.
Well, if you look at the biliary system being that drainage system of the liver that we spoke about, the most common are going to be stones and sludge. And stones and sludge in the gallbladder can form over a period of time. Now, many people, millions of people around the United States have stone or sludge in their gallbladder but have no symptoms, and it's not a problem. We see this maybe as an incidental finding when we're ordering an ultrasound for some other problem they're having, or sometimes a CT scan or imaging will determine that someone has a stone or a sludge. If it's not causing symptoms, we don't do anything about it, okay? And there are millions of people around that are asymptomatic from stones or sludge in the gallbladder. That's no problem. If, however, the stone or the sludge, the gallbladder is a storage sac. Well, it has a little tube, a little drain tube called the cystic duct. Okay, if that stone or sludge blocks the cystic duct, then you begin to have problems. That causes severe pain. We call it biliary pain or biliary colic. Okay, typically a severe pain. It could be in the epigastrium, midline in the upper abdomen, or the right upper quadrant. Usually provoked by meals, many times fatty meals, classically associated with nausea, vomiting. That's biliary colic pain. Very severe, very intense, but then if the obstruction floats up out of the way, the pain resolves. So it's transient or intermittent, comes and goes. If a patient's having those kind of symptoms, we're going to do a workup. If we see they have stones or sludge, the recommendation is going to be to have surgery, to have your gallbladder removed. You can live safely without your gallbladder. Remember, it's just a storage compartment, a small one at that. You don't need it. You can live without it. Your liver is still making the bile. You do need the bile, but the liver's making that 24 hours a day. So stones or sludge in the gallbladder itself, if they're asymptomatic, you don't do anything. If they are symptomatic from it, you take the gallbladder out. Now, a little bit different issue is if the stone or sludge forms in the main drain tube called the common bile duct, or sometimes it'll slip out of the gallbladder down into the common bile duct. Okay, so all this is just a plumbing issue. And that's when we see pancreatitis. Is if it's in the main drain tube now, and it's trying to get out into the duodenum, it's following the path of the bile, which is the fluid in that tube. But if it gets down to that little opening, which is, by the way, about the size of a ballpoint pen tip, that opening, it's very tiny, and it gets stuck, that's when you have problems, okay? You can have lots of pain. We check blood work, and we see your liver, what we call the liver function test. They are elevated, suggests there's something going on with the liver, the bile duct. If it gets stuck and it stays there long enough, or it blocks the drain tube of the pancreas, remember those two pipes merge right there, then you get pancreatitis. So that was known as gallstone pancreatitis or biliary pancreatitis.
Is there a treatment, a medicine, or something you can do to kind of move that stone along, or to remove that stone that's blocking that, so then what's coming from the pancreas can then drain?
Right. So yes, there is. So this day and age, the safest way to intervene upon the main bile duct and try to clear that duct out is a procedure, an endoscopic procedure known as ERCP, endoscopic retrograde cholangiopancreatography. It's a long name. But very simply, it is a very special design scope through the mouth, down through the stomach into the small bowel. We find the little bitty tiny pinhole. We have a catheter, insert it, inject x-ray dye, look at the anatomy under the x-ray, typically make a little cut at the opening, put a balloon catheter up, blow it up, sweep the bile duct out, it'll pull the stone out. That's well accepted. That's been around in the United States for several decades now. We do those routinely.
Outpatient?
It can be done outpatient, can be done inpatient.
Interesting.
Very common.
Is that something that you need to find early on to be able to treat that, or is that something that, by the time it's gotten to this point, it's probably decently serious?
Well, typically by the time when someone has a stone in their common bile duct tube, for the most part, they're going to be symptomatic. They're going to present with pain. They may present, if you have an obstruction in that tube. Remember, the GI tract is full of bacteria. We call it the microbiome. You've had shows about the microbiome. So there's bacteria throughout the GI tract. Well, remember, this tube is drainage. It's a one-way drainage, top to bottom. And if there is a stone or any obstruction partially blocking the tube and the flow is diminished, bacteria can migrate up into that tube, and then you have a bacterial infection back behind a blockage. That's very problematic. Then you have what's called cholangitis, okay? And that can be a lethal infection. So when people have any type of partial blockage issue, they're going to become symptomatic. Pain, nausea, vomiting, liver tests are abnormal. Usually then by imaging we'll see some abnormality. The bile duct itself may be dilated because it's blocked, those sort of things. And when we see that situation, then we're going to do one of those ERCPs to try to unblock that tube, because that is a potentially lethal problem.
Lots of great information about this whole system tonight. We still do have a few minutes when we come back. We have to take a quick break, but if you have a question or a comment, give us a call. We'll try and get you on the air when we come back with more Health Talk.
Your word is gastroenterologist.
Can I have the definition?
A physician who specializes in diseases of the digestive tract.
Can you please use that in a sentence?
When stomach pain persists, you should see a gastroenterologist.
Could you tell me where I could find one?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
G-A-S.
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me is Dr. Wayne Adkisson. He is a board-certified gastroenterologist with Sacred Heart Division of Gastroenterology Associates. You can find him at Sacred Heart at several of their offices, as well as the Endoscopy Center on Davis Highway. Tonight's topic has been pancreatitis, and we have been talking in quite a bit of detail about the pancreas and different conditions and concerns that someone might have about the pancreas. Acute pancreatitis, chronic pancreatitis, we've talked about pancreatic cancer, we've talked about some of the things that might lead to pancreatitis, like some problems in the biliary system, the gallstones or sludge or things like that. We've talked about a lot of those different things. If you have a question or a comment and you'd like to get on the air, give us a call. The numbers are on the screen. We would love to try and get you before we have to wrap up for this evening. This is also our last show of the year. So in an effort to make sure we cover all the important topics, I do want to mention briefly screening colonoscopies and how important it is that you contact your physician, that you contact the endoscopy center, that you schedule a screening colonoscopy. If you've already met your deductible for the year, you can call them and see if they have any slots available by the end of December. I don't know that they would because they're pretty busy there, but it would be a good time to think about that and get that on the schedule. Tell us briefly, Dr. Adkisson, what is a screening colonoscopy and why is it so important?
Well, a colonoscopy is an endoscopic procedure that looks into the colon, large bowel, in order to prevent and diagnose early colon cancers. So what we've learned is that colon cancer is very common in the United States and Western Europe. And it's one of the cancers that we've learned enough about now that we actually know how to prevent it. In colon cancer, your colon is the large bowel, okay? And these cancers start as little polyps, little growths that start in the very superficial interior lining of the colon. And we don't really know what causes these growths to start, and we call them polyps. And these polyps will slowly grow over time. And it's several years. It takes several years of transition from one of these polyps to grow and transition into actual cancer. But that's the sequence of events, and that's how a person develops colon cancer. Now, once the time the polyp has reached the cancer phase, then it can metastasize. It can leave the colon. And it can spread. That initially spreads to the local lymph nodes, which drain that area. Then it'll get into the vascular supply. Then it will go to the liver. Then it can go anywhere, go all over the place. So our goal is to get in there, find these polyps, to remove the polyps, and by doing so, that actually prevents colon cancer. And that has been very well delineated and validated in many studies. It is a routine part of general health care in the United States and worldwide at this point in time. So a colonoscopy is an outpatient procedure. The patient is sedated, takes about 20 minutes. All vital signs are monitored, blood pressure, pulse, respiration, oxygen levels, everything's monitored continuously through the exam. Scopes a flexible rubber tube through the rectum into the entire colon, to the end of the colon, which is going to be about 4.5 to 5 feet in the average adult. And then we start taking out polyps when we see them. Okay, and we have several methods of which to take these out. It all depends on the size of the polyp and the configuration, the way it's growing along the lining of the colon. And we remove the polyps. And that process is safe, effective, and advantageous.
And the recommendation is that you should have your first screening colonoscopy when?
At age 50. If you do not have a primary relative, mom, dad, brother, or sister with colon cancer, then you start at age 50.
And again, a screening colonoscopy is when you have no symptoms. It's like going in for a routine exam. It's going in for a mammogram or a pap smear or anything like that that's to prevent cancer. This is something that you can do. You go in for that with no symptoms whatsoever, and it can prevent colon cancer.
That's exactly right. The goal of this is to prevent. So we're doing this before the patients have developed the disease and developed the symptoms of the disease. You're trying to prevent the disease.
And if you go in at age 50 and you have a screening colonoscopy and everything is good, there's nothing at all there, then when do you have to have another one?
10 years. 10 years.
Mm-hmm. And then depending if you find any polyps, things like that, then it's going to depend on what?
Then it depends upon the number of polyps, the size of the polyps, the type of tissue that was in the polyp. Every polyp's resected, goes to the pathology labs, looked at under a microscope. So the size, the number, the type of tissue, your family history, that all kind of gets thrown into a calculation to determine your surveillance interval.
And it could be anywhere from 6 months to a year, every 3 years, every 5 years, something like that.
Right.
But this is something that is so crucially important to maintaining your health that if you have not had a screening colonoscopy and you are at the age of 50 or older, you really should contact your physician and you should have that scheduled. We do have a call that's come in, so we're going to try and get you on the air very quickly because we don't have a whole lot of time. What is your question for Dr. Adkisson?
What do you know about the URO lift?
I'm sorry, I don't understand.
URO lift?
LIFT.
Urolift. U-R-O-lift.
Urolift?
Yeah.
I'm not familiar. Tell me about it. Educate me.
It's a BPH procedure thing.
Oh, it's prostate. For benign prostatic hypertrophy. Urolift for BPH. Yeah, that's a urological issue. That is for a urologist. So that's totally out of my field.
Oh, I see. Sorry to bother you.
No problem.
Not a problem. We appreciate the call. Thank you. So again, we'll take your call if it's something having to do specifically with the pancreas or pancreatitis. That would be great. Actually, we're almost out of time, so we probably won't take any more calls this evening. But for those of you that have been watching, we certainly have appreciated doing the show, having the opportunity to talk with you about some of this stuff. It's always good to learn something new. And again, we've talked about the screening colonoscopy. That is so important. End of the year, it's time to think about your health. It's time to think about all of the great things that we've had this year, the wonderful things we're going to have in the upcoming year. One of those should be your health. So make sure you contact your physician. Make sure that you do all of those things to stay healthy in the new year. Those of you that are imbibing and that are overeating for the Christmas holidays, keep in mind that your health is important. If you have any questions or comments, of course, always call the Endoscopy Center. We hope you have a great end of the year, wonderful beginning of 2017, and we will see you next month with more Health Talk.